my name is Dr. Ankita Sethi. I am mentor of MRCOG Part 2 at StudyMedic, and today I'll be talking about PCOS. PCOS is one of the subtopic of the subfertility module. You should never stop trying, never stop believing, never give up. Your day will come. So how to excel at MRCOG Part 2 or any other exam? The most important point is you need to read, then learn, and then revise and apply the knowledge in day-to-day clinical practice. This is the only way you can excel in your exams. So the important topics that need to be covered under PCOS, which is a subfertility module, is a classification of ovulatory disorders, how to differentiate between them, and then comes PCOS. And the topics that we'll be discussing today will be the clinical presentation, investigations, diagnosis criteria, management, lifestyle modification, ovulation induction, laparoscopic ovarian drilling, and the risk of ovarian hyperstimulation syndrome and management of OHSS. Let's start with a question and then learn how to answer them. So, a couple have been diagnosed with anovulatory infertility of 2.5 years. The woman is 30 years old and has been diagnosed with PCOS. Her BMI is 25 and patient has received multiple cycles of Clomiphene. Patient does not want any intensive medical treatment. So what treatment would you recommend at this point? So we'll try to answer this question at the end of the class as well. So what's the classification of ovulatory disorders? Ovulatory disorders represent a major cause of infertility. The World Health Organization classification offers a useful frame for diagnosis and treatment by identifying 3 categories of ovulation disorders. Group 1 is hypothalamic pituitary failure, which is hypothalamic amenorrhea, or hypogonadotropic hypogonadism, which accounts for 10% of this. Group 2 is hypothalamic pituitary ovarian dysfunction or predominantly polycystic ovarian syndrome, which is 85%. And group 3 is ovarian failure or hypergonadotropic hypogonadism or ovarian insufficiency, which accounts for 5%. So the 3 types of ovulatory disorders we have discussed, that type 1 is hypothalamic pituitary failure, type 2 is hypothalamic pituitary ovarian dysfunction, and type 3 is ovarian failure. Serum FSH measurement is a very important tool to differentiate between the 3. The other things which can help in differentiating is history, examination, other hormonal investigations, and imaging. So a flowchart for investigating anovulation. According to the strategy in the RCOG, anovulation, cycle more than equal to 40 days or cycle less than equal to 40 days, and the highest progesterone is less than 15 nanomole per liter. Initial endocrine and ultrasound tests that need to be done is we need to perform a pelvic ultrasound, transvaginal. If oligomenorrhea or amenorrhea is there, FSH, LH, estradiol, prolactin needs to be done. If evidence of hyperandrogenism is there, hirsutism, acne, virilization, we need to get a total testosterone, sex hormone binding globulin done. If there is clinical evidence of thyroid disease, ask for TSH. If clinical presentation alludes to Cushing's disease, then consider referral to an endocrinologist. You need to repeat the endocrine test if FSH or LH is less than 4 international units per liter. If FSH is more than 10 international units per liter, then repeat the FSH and LH. If total testosterone is elevated, ask for total testosterone, androstenedione, DHEA, DHEAS, and if a woman is less than 30 years old, you can also get a 17-OHP done. If prolactin is elevated, ask for prolactin and macroprolactin and TSH. Repeated total testosterone twice the normal level or higher, or virilization present, or elevated 17-OHP, or elevated DHEA or DHEAS. Then you need to exclude adrenal or ovarian tumors or late onset congenital adrenal hyperplasia or Cushing's disease. At this point, consider referral to an endocrinologist. If no, then you get and you also have got a repeated elevated prolactin done. If yes, then you have to get, if TSH is abnormal, consider referral to an endocrinologist or a GP for the treatment of thyroid. If the TSH is normal, then need to diagnose the cause of hyperprolactinemia. Again, consider referral to an endocrinologist. If there is repeated elevated FSH level of more than 10, then you have to consider primary ovarian insufficiency. If no, then you need to differentiate between normogonadotropic, that is PCOS, or hypogonadotropic hypogonadism. How do you do it? You can differentiate on the basis of menstrual history. In PCOS, they generally have oligomenorrhea or amenorrhea, could have a regular menstrual cycle as well. Hypo-Hypo patients most likely are amenorrheic with complete absence of periods. Supporting history, PCOS runs in family. In hypogonadotropic hypogonadism, generally they have history of excessive exercise, anorexia, CNS disease, or anosmia. Body weight, PCOS patients are overweight. Hypo-Hypo patients are usually lean. Hirsutism is common in PCOS patients. Ovaries are polycystic in PCOS patients, and they're normal or multicystic in hypo-hypo. The endometrial lining will be more than equal to 5 mm in PCOS. It will be less than 5 mm in hypo-hypo. Uterine size will be normal in PCOS. It will typically small uterus in hypo-hypo. And progesterone withdrawal test is positive in PCOS, but it could be negative or very light bleed in hypogonadotropic hypogonadism. The LH levels in FSH LH level will be normal or raised in PCOS. FSH will be normal or low in PCOS. But in hypogonadotropic hypogonadism, both LH and FSH will be low. So referral to endocrinologist may be considered in hypogonadotropic hypogonadism to confirm the diagnosis, but in PCOS it's unlikely to be required. So what are the features of PCOS? PCOS is a heterogeneous condition which may include a variety of symptoms such as anovulation, central obesity, or clinical hyperandrogenism. Common finding on a pelvic scan is polycystic ovaries. No single feature is diagnostic of PCOS, and typically a combination of investigation is required for making a diagnosis. According to the Rotterdam Criteria, 2 out of 3 are required to confirm PCOS: oligoanovulation or anovulation, clinical hyperandrogenism, that is hirsutism or acne, or biochemical hyperandrogenism when elevated serum androgen levels are there, unilateral or bilateral polycystic ovaries on pelvic scan, where the antral follicle counts are more than equal to 12, or ovarian volume is more than equal to 10 centimeter cube. After exclusion of less common hormonal pathology, and any 2 out of 3 is present, then you can consider PCOS as a diagnosis. Although the finding of an increased LH-FSH ratio is suggestive of PCOS, its absence does not exclude diagnosis. So these points are very important, very frequently asked questions on these points. So this is a typical picture of a PCOS ovary, or we call it a PCO morphology as well. So PCOS and insulin resistance. Insulin resistance is correlated with hyperandrogenemia, that is PCOS women with high circulating androgens are more likely to have insulin resistance. By the age of 40 years, up to 40% of the women with PCOS will have type 2 diabetes mellitus or impaired glucose tolerance. Metabolic consequences include the development of the clinical metabolic syndrome with dyslipidemia, hypertension, and risk of cardiovascular events. PCOS is also known predisposing factor for developing gestational diabetes mellitus and potentially other serious placenta-mediated complications like IUGR, preeclampsia, or abruption. PCOS and endometrial cancer risk is also frequently there. Women with infrequent menstrual cycles or no natural period for at least 3 months are at a risk of developing endometrial hyperplasia, which in its complex or atypical form may even lead to endometrial cancer. These women are candidates for developing endometrial cancer before their 40s, particularly if they are obese with diabetes. Again, a very frequently asked question. PCOS and hyperandrogenism Various androgens may be elevated in PCOS, mainly free testosterone and androstenedione. Less often, other androgens originating mainly from the adrenals may also be mildly elevated. Total testosterone levels are elevated in minority of women with PCOS, about 30%. However, in the presence of normal total testosterone level, it is common to find elevated free testosterone levels combined with reduced level of sex hormone binding globulin. As the assay for measuring free testosterone demonstrates substantial variability between the labs, it is more practical to calculate the free androgen index as a measure of hyperandrogenemia. So, coming to how do you manage anovulatory infertility? The principles of management of anovulatory infertility in women are first to optimize health and weight, then to induce regular monofollicular ovulation while minimizing the risk of OHSS and multiple pregnancy. This applies not only to the women diagnosed with PCOS, but also to women in group who do not fulfill the PCOS diagnostic criteria. So the first line treatment option for PCOS patient is lifestyle modification. Several studies have shown that weight loss in overweight or obese women with PCOS improve the endocrine profile, the menstrual cycle, the rate of ovulation, and the likelihood of healthy pregnancy. Weight loss is expected to improve ovarian response and the likelihood of ovulation in women undergoing ovulation induction with pharmacological agents. It should be noted that even a small reduction in weight in the range of even 5 to 10 kg may be effective at improving the hormonal imbalance. Aerobic exercise is also recommended since it promotes weight loss. Now coming to Clomiphene citrate, which is an ovulation induction. It's a first-line drug for ovulation induction in patients with group 2. What we need to be aware about is that it has both anti-estrogenic and estrogenic properties. Clomiphene exhibits its function by blocking estrogen receptors in anterior pituitary, leading to increased secretion of FSH. Usually the starting dose is 50 mg per day. You start from day 2 or day 3 for 5 days. And in the absence of ovulation, the dose can be increased in subsequent months from 50 to 100 or from 100 to 150. If the ovulation has been confirmed at a certain dose, but the pregnancy has not occurred, the same dose of clomiphene can be used repeatedly up to 6 ovulatory cycles. The Committee on Safety of Medicines in UK has recommended that women should not take clomiphene for longer than 6 months, that is 6 cycles. Again, a very important point. So, ovulation in 70 to 85% of the patients has been reported, although only 40 to 50% will conceive. The cumulative conception rate is 67% over 6 months, with multiple pregnancy rate of 11% and a very small risk of OHSS. If ovulation has not been confirmed after using the maximum dose of clomiphene, then other methods of inducing ovulation can be explored, like ovarian drilling for PCOS or gonadotropin ovulation induction. If ovulation has been confirmed and but still there is no pregnancy has been achieved after 6 ovulatory cycles, it is likely that other factors in addition to anovulation contribute to subfertility and therefore IVF may be required. These 2 points are really important when you're answering the EMQs related to PCOS because they're asking for the management option in various clinical scenarios, and then these 2 points come into picture when you're answering these questions. Letrozole is aromatase inhibitor that is used for ovulation induction in the US and the Canada. It is very effective in inducing monoovulation, reducing the risk of multiple pregnancy and OHSS. Ovulation induction with letrozole leads to higher live birth rate compared to clomiphene. However, very important, letrozole is not licensed in UK for use in ovulation induction and as a result is not favored amongst the UK clinicians. Coming to the insulin sensitizing drugs for ovulation induction, metformin is now most widely used insulin sensitizers for induction of ovulation in women with PCOS. It has been shown to reduce serum concentrations of insulin and androgens, reduce hirsutism, and improve menstrual cycle regularity and ovulation rate. It is expected that 4 to 5 out of 10 anovulatory women with PCOS will ovulate with the use of metformin. A major advantage of using metformin is that it induces monofollicular ovulation and thereby reducing multiple pregnancy or OHSS. Metformin may also improve ovulation rates when combined with clomiphene citrate. Adding metformin to clomiphene may be considered before abandoning this line of treatment altogether. Again, a very important point when we are answering our EMQs. Metformin, most of the research studies have used 1500 milligram daily in divided doses. All the doses up to 2500 milligram daily have been used in obese patients. The drug has a favorable side effect profile with the exception of gastrointestinal disturbances. If pregnancy has occurred, metformin should be discontinued, taking into account that it is not licensed for use in pregnancy. In the field of IVF, there is accumulating evidence in support of metformin, moderating the risk of OHSS and improving clinical pregnancy rate. Now coming to ovarian drilling, which is a second-line management of PCOS and where it is indicated. It has been long known that ovarian surgery may improve the hormonal imbalance associated with PCOS. Then comes the role of minimally invasive surgical technique of ovarian drilling. Ovarian drilling involves entering through the ovarian surface with a diathermic connected sharp instrument, example diathermy needle, with the intent of reaching the ovarian stroma. By repeating this technique, a number of holes can be drilled into each ovary. Generally, 4 holes are drilled. The procedure is typically performed laparoscopically. Ovarian drilling may stimulate ovulation in up to 80% of the women who have been shown to be clomiphene resistant. The main advantage is it induces monofollicular ovulation, avoiding the risk of multiple pregnancy and OHSS. Consequently, no cycle monitoring may be required in these patients. Now coming to gonadotropin ovulation induction, where gonadotropins are used for inducing ovulation, and this is an image of multifollicular development post-gonadotropin induction. Women with or without PCOS who are resistant to clomiphene are candidates for gonadotropin. Unlike women with hypogonadotropic hypogonadism that require preparations of both FSH and LH, women with PCOS require preparation mainly with FSH only activity. The biggest disadvantage is multifollicular recruitment and its associated risk of multiple pregnancy and OHSS. And that is the advantage of ovarian drilling, where monofollicular recruitment is there and there is no risk of multiple pregnancy and OHSS. So that is the reason you need to weigh the pros and cons of both the treatment. When considering whether to opt for ovarian drilling or gonadotropin in clomiphene-resistant PCOS, one should consider the expected success, available resources, couple's expectation with regard to success against the risk of surgery or the risk of multiple pregnancy and OHSS. What are the signs and symptoms of OHSS? Very frequently asked question on OHSS. What is the history which will help us suspect a patient that may have OHSS? Time of onset of symptoms are relative to the trigger. The medication used for trigger, it was HCG or GnRH agonist. The number of follicles on final monitoring scan, the number of eggs collected, were the embryos replaced and how many, and polycystic ovarian syndrome diagnosis. What are the symptoms of OHSS? Abdominal bloating, abdominal discomfort or pain, nausea, vomiting, breathlessness, reduced urine output, leg swelling, vulval swelling, and associated comorbidities such as thrombosis. So on examination, what all things need to be seen for an OHSS patient? You need to assess the dehydration, edema, heart rate, respiratory rate, blood pressure, and body weight. On abdominal examination, you need to assess the ascites, any palpable mass, paternism, and measure the girth. Abdominal girth monitoring is very important. And on respiratory examination, you need to assess the pleural effusion, pneumonia, and pulmonary edema. What all investigations are required? Again, a very frequently asked question on OHSS, which will be asked in extended multiple choice questions. Then these investigations and the examination and history part is very important. You need to get a full blood count done, hematocrit, C-reactive protein, liver function test, coagulation profile, HCG, and an ultrasound to see the ovarian size, pelvic and abdominal free fluid. The other tests that may be indicated depending on the severity of OHSS are arterial blood gases, D-dimers, ECG, X-ray, and a CTPA if you're suspecting any kind of embolism. A proposed RCOG classification of severity of OHSS. Again, different clinical scenarios can be given. Based on that, you'll have multiple choice that you can select. They can ask details regarding signs and symptoms of OHSS, investigations, the severity of OHSS, and about the management of OHSS. Mild OHSS will have abdominal bloating, mild abdominal pain, ovarian size of less than 8 centimeter cube. Moderate OHSS, moderate abdominal pain, nausea, vomiting, ultrasound evidence of ascites, and ovarian size of 8 to 12 centimeter cube. Severe OHSS, there'll be clinical ascites, oliguria, hematocrit more than 0.45, hyponatremia, hypoosmolality, hyperkalemia, hyperproteinemia, and ovarian size of more than 12 centimeter cube. Critical OHSS, there'll be tense ascites, large hydrothorax, hematocrit of more than 0.55, white cell count of more than 25,000 per ml, there'll be oliguria, anuria, thromboembolism, or acute respiratory distress syndrome. This will be called critical OHSS. So clinicians and patients should be vigilant for the signs that the severity of OHSS is worsening. So how do we know that the symptoms are worsening? These will include increasing abdominal distension and pain, shortness of breath, tachycardia or hypotension, reduced urine output, positive fluid balance, weight gain, increased abdominal growth, and increasing hematocrit. When should a woman with OHSS be admitted? The mild to moderate OHSS can be managed in OPD setup as well. But as the symptoms are worsening, these things need to be taken into account, and then decision has to be taken regarding hospitalization. Again, a frequently asked question. So hospital admission should be considered for women who are unable to achieve satisfactory pain control, are unable to maintain adequate fluid intake due to nausea, show signs of worsening OHSS despite outpatient intervention, and are unable to attend for regular outpatient follow-up, or have critical OHSS. These are the indications for hospital admission. So far we covered the basis of anovulatory infertility. What is PCOS? What is the classification? How do you diagnose PCOS? How do they present? And then coming to the treatment options from lifestyle modification to ovulation induction, gonadotropins, and even ovarian drilling. And how gonadotropin-induced stimulation, either in the form of ovulation induction or IVF, can lead to OHSS, and what are the signs and symptoms of OHSS, and what is the management of OHSS. Now coming to the few questions. A couple have been diagnosed with anovulatory infertility of 6 years duration. The woman is 37 years old and has been diagnosed with PCOS. Her BMI is 24. She has tried Clomiphene Citrate for 6 months. Although she achieved ovulation, she has not become pregnant. What treatment would you recommend at this point? This is one of the part of the EMQs. What they generally do is they give 7 to 8 options followed by 4 clinical scenarios, and out of for every clinical scenario, one answer is correct, right? And so in this, as we have already discussed, the treatment option will be IVF because the patient is already 37 years old And she's already taken 6 cycles of Clomiphene citrate where ovulation was documented. Now, there might be some other cause of subfertility, and therefore, the next line of management is IVF. A couple have been diagnosed with anovulatory infertility for 2 years duration. Woman is 25 years old, diagnosed with PCOS, and her BMI is 23. What treatment would you recommend at this date? IVF, lifestyle modification, ovarian drilling, ovulation induction with Clomid, or ovulation induction with gonadotropin. So as you can see, she's a young patient with anovulatory infertility and a BMI of 23. So the patient is not obese. So the treatment option will be ovulation induction with Clomid. If the patient would have been obese or the BMI would have been 29, then maybe the first line of management that you can mention is lifestyle modification followed by ovulation induction with Clomid. So the next question is, a 25-year-old woman with known PCOS has been receiving ovulation induction with gonadotropins. The monitoring scan revealed a single follicle of 18 millimeter, numerous small follicles between 11 to 14 millimeter on the day she received a trigger. She presented with gradually increasing abdominal tension and nausea about 2 weeks after her trigger. So as you can see, that the patient was receiving gonadotropin. There was a single large follicle of 18 millimeter, but there were numerous small follicles from 11 to 14 millimeter. And the symptoms are gradually increasing distension and nausea. This is pointing towards ovarian hyperstimulation syndrome. A 24-year-old presents with 18-month history of amenorrhea since stopping the oral contraceptive pill 18 months ago in order to try for pregnancy. She had been on compiled pills since she was 16, and during which time her periods were regular. Her BMI currently is 31. What is the most appropriate next step for investigations? So the patient was continuously on oral contraceptive pills, and when she stopped it, she had 18-month history of amenorrhea. This could, plus the BMI is 31. So a hormone profile to check SHBG, free testosterone, FSH, LH, and prolactin will help us answer the questions that why she's not having regular periods. Thank you. So I tried covering PCOS, the important points, the important questions in which forms they can be asked, and this will help you answer majority of the questions related to PCOS under the subfertility module. Thank you.